Good morning, everyone. Power is getting restored gradually around here. Looks like the north side of M60 is starting to get power. Some of the south side started to get power last night. So their consumers is making progress. The word for the campus was Sunday, but the generators across the street are off. So parts of the campus have power. So that's progress. So hopefully by the time things get back to normal Monday, we'll be all set. So I hope you guys are all well. I don't know if you're home or if you're on campus, but whatever the case, I hope you're well. I think it's appropriate we pray before we start. Lord, you told the Pharisees that it is not the healthy who need a physician, but the sick. And that they should go and learn what it means that you do not desire sacrifice, but mercy. Or you have not come to call the righteous, but sinners. Lord, we come to you as sinners, called by you, saved by grace. We thank you for that grace that saves and empowers us to serve, even as healers, or in my case, as an instructor. Thank you for this time. May this time be used well. Please help those who don't have power get it back quickly. In Jesus' name, amen. Now, I thought we might want to cover something that you guys might not yet be completely aware of. So, when you consider the skull, beneath the skull, you have the dura mater. But here's the part about the dura you might not be aware of. The dura has an outer layer and an inner layer. And as you can see, that outer layer lies right against the periosteum of the skull. So that would be right against the skull. The inner layer, the meningeal layer, separates the two, and there is a space between the two. And that's a subdural space. Now, it turns out that the arteries for the brain are in the subarachnoid space. They are drained, those arteries are drained by veins that drain into the sinuses. And these are called dural sinuses. Now, the dural sinuses look like this. These dural sinuses drain the blood that leads to the brain. And the veins that provide drainage from the blood supply that goes to the brain, these veins are called bridging veins. So when I mentioned that term bridging vein last time, I don't know how many of you understood that term, but that term refers to these veins that drain the arterial blood that goes into the parenchyma of the brain and drains it into this subdural space. So, if you have a subdural hemorrhage, it's these bridging veins that get stretched and damaged. And because they get stretched and damaged, you have a bleed into this subdural space, and it's the veins that get stretched. The arteries, because they're in the subarachnoid space, they're not of any concern in that case. It's the bridging veins that are subject to that stretching. I hope that helps you understand essentially how you get the subdural hematomas with the stretching of those bridging veins. So if you go back to our discussion about epidural, subdural, and intracerebral, and then subarachnoid hemorrhages. We can see that the main cause of the subdural hemorrhage is rupture of the bridging veins. When the bridging vein blood vessel is damaged, it will create an active bleed. The bleed is a hemorrhage. A collection of blood is known as a hematoma. The elderly who have brain atrophy, whereby the brain shrinks in size, their bridging veins will be stretched across a wider space, and they will be largely unsupported, kind of like a rickety bridge across a mountain pass. The other group that will have fragile bridging veins are infants and those who abuse alcohol. The veins are thin-walled, so they're more likely to break. So subdural hematomas will be common after head traumas, like falling in a wet bathtub and whacking your head, or in the case of shaken baby syndrome, where a baby might be violently shaken. And as we said before, as that brain gets rolled around, essentially shaken back and forth, those bridging veins, essentially, as this goes back and forth, will be stretched as the baby is shaken. Subdural hematomas can also occur after an acceleration-deceleration injury. For example, speeding on the road and then suddenly slamming on the brakes, that movement of the head forward and back in the skull. That can cause a subdural hematoma as well. So regardless of the mechanism, once the bridging vein gets torn, the blood will pool in that subdural area, just like you see here on the slide. That creates a hematoma. Since you have damaged bridging veins that are under relatively low pressure, the bleeding will be slow and will show a delayed onset of symptoms. The symptoms will develop over a course of days to weeks as the hematoma will gradually expand. So the acute subdural hematoma causes symptoms after 2 days. Subacute will cause symptoms between 3 to 14 days. Chronic subdural hematoma will cause symptoms after 15 days. The hematoma can compress the brain. It can cause increased intracranial pressure. And a large subdural hematoma on one side of the brain can cause a midline shift, whereby the midline gets displaced to the other side of the brain. And increased intracranial pressure, of course, can lead to brain herniation. The most common signs and symptoms of a subdural hematoma will usually be loss of consciousness. That loss of consciousness will occur right after the injury. You also might have loss of consciousness in the ensuing days to weeks after the injury. Other symptoms will include things like a headache, and vomiting. Sometimes you can have focal neurologic symptoms. These might include things like muscle weakness, or sensory problems. And this depends on the location of the hematoma. Now, if you do a CT scan, you're going to see something different than what you see with an epidural hematoma. So this is like what you see. So you have this area here that is hypodense opposed to the brain parenchyma. The bleed goes with the line of the brain because the bleed is on top of the brain. The bleed also, the area of the bleed will cross suture lines. That is not the case with an epidural hematoma. With an epidural hematoma, because the brain is attached more tightly at sutures, the bleed will be between suture lines and the bleed will be biconvex. It will look more like this. This is a very typical epidural hematoma where you have that biconvex shape, but it doesn't cross the suture lines. The subdural hematoma will cross suture lines and it will be more crescent shaped and go along the outline of the brain. Also, another word about subdural hematomas. Sometimes, if these bleeds are long-term, some of the blood can clot. And so you might have areas that are actually, they're different density than the parenchyma, but they're darker than what you see here. This is an acute subdural hematoma. Also, if you get a rebleed, so if the bridging veins get damaged again, part of this can look light and the other part of it will be dense. So these can have a different appearance depending upon when the bleed happened and whether it's a chronic or acute bleed or something like that. Small bleeds are drained by placing a tube. In here, it's a catheter. You place that in after you drill a hole in the skull. Large bleeds, like this one, you would treat with a craniotomy to remove this part of the skull so that the blood can escape. And again, folks, if you have questions, please dive right in, ask. Don't send me a note because I won't read it. I won't see it. The chat function, unfortunately, you don't get a big note like you used to on these. Now, let's talk about a bleed that's not on here, and that is a subarachnoid hemorrhage. So let's go back then to our picture. So with a subarachnoid bleed, you're bleeding into the subarachnoid space. Because arteries occupy this space, those bleeds are usually going to be arterial. So you get a pool of blood under the arachnoid mater. So the bleed is usually a tributary of the artery. You're going to get a bleed right in here. That will increase intracranial pressure, prevent more blood from flowing. So because the arteries are out here, you're going to push essentially this way on that artery, is going to tend to shut that artery down. So you will cause ischemia to other parts of the brain. Now, I feel like I'm doing one of those commercials, those anti-drug commercials. This is your brain on, whatever. Anyway, now the brain has a very interesting circulatory system. And I'm going to remove the cerebellum here because this will be easier to indicate if I do this. So the internal carotids come on either side like this, bonk, bonk, like that. And then there is a vessel that's going to come up. You're going to have two vertebral arteries that come up like this, and they're going to fuse here into something called the basilar artery. So the basilar artery comes up here, the middle carotid comes up here at the middle, internal carotid comes here, and it forms a circle of blood vessels. And that, I'm going to try and draw it, but you guys know I don't draw very well. So I will give this a good college try. So you have the middle carotids, internal carotids, sorry. And then you have the basilar, like this. And this is anterior, this is posterior, just to orient you. Now, so internal carotids, basilar. This circle is going to surround this structure right here. It goes around the optic chiasm, the pituitary, and it's going to circle like this. This is called the circle of Willis. Why is this important? This is important because you have high turbulence in this area. Because you have high turbulence in this area, areas of these vessels can weaken and they can bulge out like that. And that's called an aneurysm. And if these aneurysms bulge out, they can pop. And if they pop, they're going to cause a subarachnoid hematoma or hemorrhage. So that is one of the causes of this, is a aneurysm that forms, and they most commonly form within the circle of Willis. Now, these other vessels here, so these come into the circle, basilar, internal, that you have what's called the posterior communicating vessel or posterior communicating artery. And this, you guessed it, is the anterior communicating artery. This then produces the anterior cerebral vessels. There will be another set of vessels that will issue off from here. So these, this part here will produce two vessels that go in the back like this. Those are the posterior cerebral vessels. And then from here, there are some vessels that will go this way, and those are the middle cerebral vessels. CV, cerebral vessels. I'm running out of room. These vessels as well can be subject to damage, and they can be subject to damage in a couple of ways. So the posterior cerebral vessels are going to provide, oh, I need to move this up. Will provide blood to the occipital lobe and this portion here of the temporal lobe and a little bit of the parietal lobe too. The anterior cerebral vessels will provide blood essentially for the frontal lobe, and then going over this part here of the motor and sensory cortex like this. And then the rest of this here, so this part here and this part here, that's going to be this middle cerebral vessel. And most of the time, if there's damage to any of this, it's going to be to the middle cerebral vessels. Now, I'm going to keep this picture here, and I'm going to try and write on this because I want you to kind of keep this in mind. This is going to be hard to do. Let me see if, well, if I get rid of that thing up there, well, yeah, I'll just do my best here. There. These can be blocked either by atherosclerotic plaques. Atherosclerotic plaques result from increased low-density lipoprotein particles. These, if they rupture, they can undergo a clot formation. So in that case, they're called a thrombotic. It's a thrombotic plug, and that will cause thrombotic ischemia. Or you can have a clot that forms someplace else on the body and floated to that area, in which case you have what's called an embolic case of embolic ischemia. So the first cause of the subarachnoid hemorrhages is an aneurysm. The blood vessel wall weakens, it starts to bulge out. And if they bulge out and pop, that will cause a subarachnoid hemorrhage. And there are several pictures of these in your book. The most common one is the one I've drawn here, is a so-called Berry aneurysm. And they tend to form around the circle of Willis. They can theoretically form anywhere, but they most commonly form around the circle of Willis. Also, certain genetic conditions can make aneurysms more likely. So for example, people who have People have Marfan syndrome. They are at increased risk for aneurysms, and people with Ehlers-Danlos syndrome. Both of these genetic conditions increase your risk of aneurysm. Because this is a defect in collagen cross-linking. Collagen is part of the basement membrane upon which the endothelium sits. Marfan syndrome is a problem with elastin. So now the vessels are stiff and not elastic. All right, so back to aneurysms. Second most common cause would be a traumatic injury. So some sort of traumatic injury, falling in the bathtub, hitting your head, something like that, those can also rupture these vessels as well. Now, the arteries in the subarachnoid space, they're not terribly well supported. They can easily break. And the third cause of a subarachnoid hemorrhage would be some sort of deformation, some sort of malformation in the way the vessels are made. So typically, you have arteries, and those arteries essentially give way to veins. And you have some sort of capillaries here. If these capillaries are badly formed so that they form kind of a knot, those knots are under very, very high shear forces as the liquid flows through them, and they're subject to leaking. So these are called arteriovenous malformations. These will leak. And if they leak, the blood will essentially spew from a damaged vessel. It'll create a pool of blood that increases pressure in the skull, puts direct pressure on nearby tissues, cells, and blood vessels. So you have less blood flowing downstream to cells that need it. That leaves the downstream tissue deprived of oxygen-rich blood. And so the healthy tissue can die in this case either from ischemia and a lack of oxygen, or the fact that the blood vessels are bathing in a pool of blood. If you get these vessels now bathing in a pool of blood, these vessels respond by undergoing vasoconstriction. And that vasoconstriction it's a vasospasm. That can affect the arteries in the circle of Willis. That will decrease blood flow to the brain, further ischemic damage, and over time, the subarachnoid space, if there's blood in it, it can irritate the meninges. You can get scarring of the surrounding tissue, and then that scar tissue can build up. It'll dilate the ventricles at the center of the brain and produce hydrocephalus. So this essentially is a bleed really within, more within the tissue of the brain. And this, of course, leads very much towards the subject of strokes, which we'll cover right after we finish these other aspects of injury to the brain. We'll get to stroke here in just a bit. All right, intracerebral hematomas. So the cause in this case is usually due to weak vessels in the brain, and the biggest contributor towards those weak vessels is hypertension. And with the case of hypertension, we need to go back to the blackboard here and show you what happens with this. So here's the lumen of the vessel, and here's the other stuff in the vessel, and so on and so forth. And here's your smooth muscle layer. And so this is one of the small vessels, say, in the brain. And then here's the other bits and pieces essentially associated with that. Now, if you have hypertension, this increased pressure is going to start to push protein and things like this in between the intima and the smooth muscle. So here's what happens then. You get this vessel and now you have your layer of smooth muscle, all this other stuff. But that layer of protein and what have you, essentially, is now going to line up here like this. And now you get a vessel that is really, really small. These vessels are not only small, they're very fragile. This is called hyaline arteriolosclerosis. And they are the direct result of uncontrolled hypertension. You can see why it's so important now to control blood pressure, don't you? The other thing that can affect vessels is the deposition of amyloid in the vessels, and amyloid deposition can also weaken the vessel and make them more prone to rupture. And then, of course, aneurysms and stuff like that. There are also vascular tumors. These vascular tumors are called hemangiomas. Hemangiomas can put pressure on vessels. You essentially have this monstrous tumor out here that's putting pressure on the vessel, and that's weakening it as well. Whatever the case, the vessel is weak and it pops. And you get a bleed essentially in the brain parenchyma. So the bleed typically begins slowly and then it worsens gradually. As the hematoma enlarges, like you see here, you get increased intracranial pressure. So you have altered consciousness and headache, nausea, vomiting, and the pupils now are of unequal size. And typically also because of the inflammation, there's also a fever. Depending on the area of the brain that's affected, you may also see different focal signs. So if it's the anterior part of the brain that's affected, you may get numbness or sudden muscle weakness. If it's the posterior side of the brain, you may see impaired vision. If the Broca's area on the side in the frontal lobe, but back towards the side is affected, you may have slurred speech. And if the Wernicke's area is affected, you might get difficulty understanding speech. And what have you. And these are usually determined by virtue of a CT scan. And I'll just give you an idea of what these look like on a CT scan. I have one here to show you. You can see on a CT scan, that's pretty hard to miss. So, and this is why you do these CT scans with no contrast. When you do them with no contrast, blood comes out really easily seen. So that's essentially what you see on a CT scan. All right. So open brain injuries will expose the dura and the cranial contents to the environment, and that can cause a variety of different issues. It depends where in the brain you have it being exposed. That will determine the focal nature of the brain injury. Diffuse axonal injury refers to shearing of axons of neurons. This is usually due to rotational forces in the brain. It can be due to acceleration, deceleration, but it's almost usually associated with some sort of rotational force. And that rotational force tends to create some sort of rotational force that shears, stretches the nerve fibers. In this case, on the CT scan, you don't see an obvious bleed, but the patient may present with a deep coma without elevated intracranial pressure, because again, you don't have a bleed. So the patients are comatose, and you typically get lesions at the gray-white junction. That's what you usually see in the CT scan. So to give you an idea of what a DAI injury looks like, so here's a case study that shows you essentially what this looks like. So a 20-year-old man is brought to the ED following a motor vehicle crash in which he was the restrained driver and he crashed into a standing car. So there's acceleration, deceleration. In the ambulance, the patient is obtunded. Obtunded just means that they don't respond to any sort of stimulus. Glasgow scale of 4, ooh, that's bad. Upon arrival, he's intubated immediately. He's lower than 8, so you intubate. Take him for trauma CT, multiple lesions at the gray-white junction. When you see gray-white junction, think DAI. Vital signs are within normal limits. Day later, patient remains in a coma without change on the Glasgow scale despite ventilation and sedation weaning strategies. Which of the following best explains the clinical presentation? Rupture of the MMA? Nope. That would be the case of an epidural. sort of hematoma. Rupture of the bridging veins, no, that's indicative of a subdural. Also, this one, the onset's going to be gradual, not immediate like you see here. Neurotransmitter-mediated excitotoxicity. That's what you'll see in a stroke usually. So no, and seizures and that sort of thing. Shearing of the white matter tracts. Yes, yes. Hypoperfusion, that's what you're going to see with a bleed, like a subarachnoid bleed. No, the answer here is D. And the answer here is D. You have shearing of these axonal tracts, commonly seen in crashes with acceleration, deceleration. Patients are comatose without elevated ICP at presentation. That's very, very important to remember that. Comatose without elevated ICP. And so you essentially get, this is kind of the summary, shearing forces, prolonged post-traumatic coma, up to 6 hours, not explained by mass lesion, lasting cognitive deficit. Brain CT shows hyperdense punctate lesions along the gray-white matter junction, like you see here. That's small, I realize, but oh, that still doesn't help, does it? Get me focus here. Okay. Best diagnosis, of course, is with an MRI, but the CT you'll need for the emergency use here. We already talked about concussion, so I'm not going to go over concussion much more. We talked about the different types of concussions. That's really as far as I will go with that. Keep in mind that after a brain injury, trauma to blood vessels can create the opportunity for strokes because you've damaged vessels. Strokes are a definite possibility. And you can also have seizures. Seizures result from excessive excitatory postsynaptic potentials without any inhibitory postsynaptic potentials. They keep those excitatory postsynaptic potentials in check. Consequently, excitatory postsynaptic potentials take over the brain, and the patient will start to experience seizures. So seizures are an important post-trauma consequence. And that will challenge your management, usually, of the patient. Post-concussion syndrome, where someone essentially feels dopey, they have some cognitive deficits, they can't find words, that sort of thing, or headaches, ringing in the head or bad headaches. Those can last a while. You can even have those without really having a very severe concussion in some cases. Post-traumatic seizures, these can last a week or two, a month or two, or years. So you see here within days to 2.5 years post-injury. When that happens, then you have to manage them with anti-seizure medications. And that is due to a hyperexcitable state, or it's due to a hyperexcitable state that's due to injuries of regulatory parts of the brain that regulate excitatory states. So it could be too much of stimulatory areas, or it could be not enough of the inhibitory areas. It could be either one. Okay, we can't see you, so we'll hide you. There we go. And CTE is a result of chronic sort of damage to the brain, and the accumulation of that damage causes CTE. Spinal cord injury, is usually due to trauma to the spinal cord. If you have repeated trauma to the spinal cord that is moderate, say you're lifting more than you should be lifting, or you're not lifting with proper technique, then the discs themselves may start to undergo damage and you can get degenerative disc disease. Any one of these can put pressure on the spinal cord. So the pathophysiology of this depends on how bad the injury is and where in the spinal cord the injury happens to occur. Spinal cord injuries can range from simple fractures of the vertebrae. Some of these simple fractures can, they can hurt, but they can heal usually without an issue. Or you can get so-called wedged fractures where the centrum essentially gets crushed and it gets crushed in a wedge-like fashion, or a comminuted fracture where the centrum just bursts essentially. Or you can have dislocation. Those dislocations can be mild or they can be really severe. And compressing, pulling, shearing forces, or sometimes penetrating wounds, also through stabbing or accidents sometimes that cause penetrating wounds. Those can also cause injuries to the vertebral column as well. So in this case, as you see, where the head gets propelled back like this, the spinal cord gets hyperextended. This extension can cause problems, number one, with the ligaments. So the ligament that is going to coat essentially the spinal cord, the bones at least of the vertebral column, those can be stretched and damaged, as can essentially parts of either the centrum, as the centrum here gets butted against another one, or parts of the spinous processes, they can get crushed. Or you get stretching and the discs here, notice how the discs get compressed. That can cause the disc to start to bulge and get damaged and stuff like that. And if a disc bulge, it's going to impinge on the spinal cord. This can go the other way, where the head essentially is propelled in this direction here. And now you get wedge fractures, as they're called. This can also stretch the ligaments and what have you. And that wedge fracture can cause other types of issues, whereby the spinal cord might impinge on other structures like the inferior vena cava or something like that. Or if it's in the neck, it can cause other types of problems. It can cause problems with, for example, the brachial plexus that goes into the arm. You can get arm issues and what have you. Then essentially, when you have kind of a force that goes high up in this way, essentially on the spine, that can essentially cause, you don't have cord compression, because essentially you don't have anything going either this way, or it's not swinging this way or this way, but you have kind of a direct force this way. That can cause compression fractures, but without cord compression. Or if you crush the centrum in general, now that causes cord compression. Twisting of the spine. Twisting of the spine often puts a lot of pressure on the discs. The discs will start to bulge. You can essentially cause the spine to be dislocated. If you dislocate the spine, that can cause a lot of trouble for the discs. And then the discs will, as you can see, will impinge on the spinal cord. A blow to the spinal cord can send lots and lots of excitatory postsynaptic potentials into the spine. That extreme level of EPSP can cause the muscles essentially to, this is a little hard to explain. I think the best way to explain it is that the muscles get such a large dose of excitatory signals that they get drained essentially of their ability to start another action potential. Also, you send signals up to the brain, and the brain gets overloaded, and you essentially you either lose consciousness or you lose the ability to move. Fortunately, this is temporary. So it's a blow that doesn't cause, well, most of the time at least, any lasting damage to the spine. That's called spinal shock. Fortunately, this is temporary, but it can cause loss of reflex function in the bladder and the bowel and thermal control and things like that. And that's if you get a blow to the spine that doesn't cause any spinal issues. Now, if you transect the spine, now you're going to have a loss of feeling and motor control below the level of that injury. If the spine is hemitransected, you will lose feeling on the ipsilateral side, but you will lose motor control. Sorry, you will lose motor control on the ipsilateral side, but you'll lose feeling and sensation on the contralateral side. That's called the Brown-Sequard syndrome. Brown-Sequard syndrome. Brown, BROWN-SEQUARD syndrome. That's that's very common with stabbing wounds, where you transect the spine, but you transect only one side of it. Now, if you transect the whole spine and you transect above, you get injuries above T5. Now you're going to have absence of sympathetic activity and unopposed parasympathetic tone, and this causes something called autonomic hyperreflexia. So in response to this unopposed sympathetic tone, the sympathetic nervous system takes over and tries to overcompensate. So you get this uncompensated cardiovascular response. The heart beats really, really quickly. You get systemic vasoconstriction in the peripheral vascular system, and stimulation of the sensory receptors below the level of the cord lesion can fail to occur. So this illustrates it here, I think, pretty nicely. So with visceral distension, the bowel, the bladder, the abdomen, you have pain receptors in the lower levels. Spinothalamic tracts carry those impulses to the brain. The brain interprets that sensory information, and then the corticospinal tracts, in response from that sensory information, they will carry proper motor impulses down to the muscles, and you empty your bladder, you remove the thorn that's stuck in your foot or something like that, and that fixes everything. If you transect here like this, and it is above, as we said, it's above T5, now you get that spinothalamic tract wanting to carry that sensory information, but it gets headed off at the pass. So because that reflex stimulus is going to activate, because the sympathetic nervous system undergoes mass activation, unlike the parasympathetic nervous system, you get increased blood pressure that stimulates the carotid sinus receptors. The ninth cranial nerve, stimulated by the carotid sinus receptors, sends signals to the vasomotor receptors in the medulla, and it sends impulses to the SA node. Initially, because the vagus nerve is stimulated, the heart rate is going to go up, but then the autonomic response to hypertension will cause arterial dilation, flushing of the skin, headache, and sweating. So because you get this autonomic hyperreflexia, that hyperreflexia is opposed by the activity of the vagus nerve. The vagus nerve is probably except in the face, it's one of the biggest transmitter of parasympathetic impulses throughout the body. This essentially is a result of this autonomic hyperreflexia, first from the sympathetic and then from the parasympathetic. Lower back pain is usually idiopathic. Nobody knows why it occurs. Could be chronic, could be acute. Degenerative disc disease is usually due to the loss of water in those cartilage discs. Spondylolysis is a stress fracture of the centrum of the vertebrae. It can really hurt, but with proper exercises and back support, it can heal. Spondylolisthesis is a slipping of the disc and the vertebral centrum. So it slips out of place, and it usually slips forward when it slips forward. And so it's completely out of place and it needs to be put back. And then spinal stenosis means that the cavity that carries the spinal cord gets small, either due to a bulging disc or bone spurs or scar tissue or something like that. That impinges on the spine and causes damage. And then herniated discs, of course, because the center of the disc, the nucleus pulposus, lacks water, it can rupture. That's usually caused by trauma, degenerative disc disease. Radiculopathy is usually a root pain. It's a neurologic pain that shoots down the leg, down the back of the leg, down the arm, something like that. And it can cause kind of a numbness and pins and needles feeling. That's paresthesia, or of course, pain. So patient is told he or she has spondylolisthesis, which best describes the condition. Spinal stenosis, nope. Radiculopathy, nope. Forward displacement of the vertebrae, yep, that's what it is. That's the answer. Degenerative process of the vertebral column, no. This means that the vertebra itself has juts forward. That's spondylolisthesis. Very good. This is a good place to stop. So Monday, we will pick up and talk about strokes, and we'll get into the different types of strokes and how they affect neurological function. I hope you guys have a lovely weekend. Please watch your emails and the Blackboard site for quizzes and things like that. Have a great day.
Thank you.
You're very welcome.